Hello, I'm Peter Lachman, the Clinical Director nationally for the SAFE program, Situation Awareness for Everyone, run by the Royal College of Pediatrics and Child Health and funded by the Health Foundation. This talk is going to talk about how to do the huddles based on the theory that we discussed earlier in the patient safety section and the theory on improvement methodology. Now, if you recall earlier, the theory of change really determines on what you're going to do. So the first thing when you decide to do the huddle is to study your process and come up with a theory of change. And in this example, I'm giving you the theories of change. Over here, you can see the increased number of days between unexpected transfers to a higher level of care. It could be also increasing the number of days between your 222 crash calls, increasing the number of days between deteriorations, increasing the number of days between any activity that you want to prevent. We then look at the different key drivers that are required, and leadership is always there. How are you going to lead? How are you going to communicate? Do you have early warning systems? Do you use huddles, which is one of the intervention? And what training do you need for all the people? Now, the Situation for Awareness program comes from Cincinnati Children's Hospital, who published a number of articles a few years ago based on their experience of introducing huddles as a key component of their patient safety program. And what they saw was that the number of transfers to intensive care went down by 2/3, and they called them the unplanned transfers, those that weren't planned as part of the care for the child. So, for example, if the child was going to have an operation and it was transferred in a way that was not planned, they would consider that as a risk to the child. If the child was going to the ICU as part of their planned care, then it would not be counted as a risk to the child. They studied the change in culture, the way things happened in order to achieve high reliability. What they were doing is the huddle that we've adapted for the United Kingdom, and they were doing it to achieve high reliability for the system. Now, we have been doing this here in the UK for a number of years. We started the program in 2014. It ended in 2016. But in reality, we started testing both at Great Ormond Street Hospital and the Royal Free Hospital in 2012 and 13, testing the different components of this so that by the time they published their papers, we were ready to go. And in 2014, we had the study of first 12 hospitals, then another 16 on implementing the program. Here you can see some of the papers that we've published so far, and more are in the pipeline. These papers allowed us to understand that in order to decrease the deterioration, what we are really looking is the way of the microsystem working, the way we can change microsystems and improve team culture, improve communication, and make sure that we are all on the same page when we talk about children. Everyone has part of the truth. Now, situation awareness is a pretty old concept. It comes from studying the military, firstly in the First World War, and later in other areas. It is a key part of the concept of mindfulness and the concepts of high reliability. And Endley, who wrote the first studies on this, said it's a perception of elements in environment within a volume of time and space, the comprehension of their meaning, and the projection of the status for the future. So simply, it's like taking what is happening now, getting many different views so you make sure what is happening, and then projecting what's going to happen in the future. This is called mindfulness, knowing what's going on before it actually is going to happen. Now, a good example is if you watch a team. So if you watch a good, say, rugby team, like the All Blacks, you often wonder, how do the players know where to be when the ball is passed? If you watch a good football team, Real Madrid, Barcelona, you wonder, how do they know where their players are going to be in order to get the ball? It's because they practice, they practice, they practice. They keep to the drill, they know exactly what's going to happen, and they're always a few moves ahead of the opponents. A good chess player is key in understanding anticipation, knowing what his opponent's going to do before the opponent even is going to do it. So the moves are always anticipating what's going to happen. This is all about mindfulness. And what we're trying to create in situation awareness is mindfulness for a whole team, so that everyone understands what the situation is. Now, situation awareness can be depicted like this. You gather information, you recognize it, and then you anticipate. Perception, comprehension, projection, and then that determines what you're going to do. That is situation awareness. And it's very important to understand that the huddle is aimed at improving situation awareness. And the theory is that if you improve situation awareness, then you will decrease harm because you'll anticipate, you'll project, and you'll mitigate. We are going to apply this to the huddle and what you're going to do. So the concept of the huddle is to provide the forum to develop good situation awareness, mindfulness, and understanding so that you can predict and project the future rather than what we normally do is react to events. Mindfulness is what it's all about. Now, mindfulness can happen both at a team level as well as at an individual level. And if you recall earlier when I spoke about the moving from reactive up to generative and proactive cultures, it was moving up different levels of mindfulness, using information, and that's exactly what we're going to try to do here. This requires us to think differently. We have been taught to react, to crisis manage. We're very good at that, and we quite enjoy it, I think. What we really want to do is decrease crisis so that we are predicting what's going to happen. And to do that, you have to think differently. You have to design differently. The huddle and the implementation of this program on SAFE aims at changing the way you do things, so things will be different. And if it's not different, then you're not doing it, and we really need to look why. But let's get back to basics. This has to be done by the front line. It cannot be edicted from above. People can't be told to do huddles because they have to. They have to want to do it. They basically have to own the process. That's why it's so important to study your microsystem, look who's important, who are the key people who have to be there, and how can they own the process. They must not see it as a burden, but as a benefit. There must be relative advantage to the new way over the old. So what we're going to do is transform this complex patient safety theories and methodologies into day-to-day clinical practice so that patient safety is your business and this is what you're doing. You're constantly doing something to make the children safer and constantly improving. We're going to integrate human factors, reliability theory, quality planning, learning from excellence, safety 2, which is resilience theory, all together. We're going to bring these all together into a meeting that happens 2 or 3 or 4 times a day on your ward, in your clinical areas, where the teams come together and apply these theories in real time and improve for the next 6 to 8 hours. How often you do it, that's up to you, depends on your context. We don't have rules. We say study your context and apply the principles. The idea, this is about predicting what's going to happen rather than reacting to what happens, which is what you do on the ward rounds. Now, this is the Cincinnati model that we want to do. First of all, you identify. That happens at the bedside. That usually is the doctor or nurse, the house staff or nurse, coming together with the parent or the family members and identifying who's at risk. The second part is to mitigate. That's the huddle over here. That is where the huddle, but here they have a senior resident, that would be the registrar, the watch stander of the people coming from the bed, the charge nurse, and the attending, which is the consultant. They come together at the huddle and decide which children require escalation or mitigation. And they feed back. This is very similar to the model that we gave for situation awareness, in which you perceive, you comprehend, and then you act. And that's what they're doing here. They're identifying, they're comprehending, and then they're acting. But how do they identify? Cincinnati had 5 key factors. I've added a few more. These are the very important ones. The first is, are there any family concerns? Have the family raised any issues? Never ever disregard what the mother says. The mother knows the child best. So are there family concerns? Secondly, is the child on high-risk therapies? Depending on where you are in your context, the child may be on high-risk therapies or therapies you don't normally use, or the child may be in an area like an ICU where they're always on high-risk therapies. Are there unusual high-risk therapies? That's what we're looking for. The third one is if the early warning score is above your limit. Here they use one with 5. It depends which early warning score you are. Remember, the early warning score is part of a system, and this is part of the system. We want to know, what is the early warning score? Is it going up? That's more important than if it's just high. Has it changed? They introduced something called a watcher. This comes from, actually from the military, from aircraft carriers. And the watcher is the person who watches the top ace pilot land the plane. And when you're landing on an aircraft carrier, you have a very small degree that you can come through, which is about 3 degrees. And the watcher is watching the plane come in and telling the pilot to correct. They took that concept and they brought it into the healthcare. And they said the watcher is someone who the nursing staff or anyone feels we need to watch because something's going on, even though the vital signs are normal. It's the ones that the nurses often tell us, I told you so. So we're trying to detect them. So anyone who feels they've got a gut feeling there's something wrong with the child, we need to know. So, for example, at the Royal Free Hospital, the school teacher will say, the child's just not learning well today. And the doctors will say, but the vital signs are normal. But she says, no, the child's not learning that well today. Something's going on. It's these subtle changes that come into this one. You then look at the communication issues. This is mainly aimed at children's hospital when there's more than one clinical team, or it could be that the parents don't speak English or the child doesn't speak English, so anything with communication issues. There's one with the wrong bed. I put that in because a child who's not in the right bed, is on the wrong ward, is at risk. And finally, one that I have just added is the child who's stable. Children are supposed to either get worse or get better. If they're just stable, they're not getting better. An example is a baby that has bronchiolitis and is stable, but the work of breathing is going up and up and up, and suddenly the baby deteriorates. Babies should be getting better, not being stable. So that is a key thing. If a child is stable, we put him on this list. Now, these are the ways they identify children who need to be discussed, and this is something that you'll be doing. We have called these the children we need to watch. And we need to and watch means which children we may be concerned about deteriorating because they have any of these factors. So the process of setting up the huddle is firstly to understand the theory, get your team on board, and really start going and looking at what the aim of your huddle is. I've seen different types of huddles. At Sydney Children's on the ICU, they had a huddle for the allied professionals who found going on ward rounds a waste of time because they only got to know what they need to do for 1 or 2 minutes per child. So they had a huddle to inform the allied professionals all about the children that needed to have interventions. That was the aim of that huddle. I've seen huddles aimed at decreasing medication harm called the druggle. That kind of huddle has got a specific aim. There are other huddles that are aimed at decreasing deterioration. That's the one we concentrated on. So decide what your aim is. You then have a method and a process. How often should they happen? Usually start once a day because you're testing. see when the best time they should be had. You're testing how they work, when it should happen, how often, who should be there, where it is to be held. Often a big problem. In the open ward, in a special room, people are worried about confidentiality. How are you going to do it? How are you going to keep notes? Do you have a set script? We really recommend set scripts, and we've got a number of examples on the website that you can look at. Who needs to be there? Which members of staff? How are they going to be there? Have they got other commitments? What are they going to do? How are you going to be inclusive? It's very important to be inclusive. Who's going to lead the huddle? It doesn't have to be the same person every day, but you need a leader of the huddle who's going to make sure it happens and make sure that you follow through. A clear direction of what is needed and the information required, so that people who come into the huddle know what you're going to do. We recommend that you have a communication tool, talk in SBAR, background assessment and recommendation, but very brief. This is not a ward round. It's not a handover. It is a transfer of information so that people can get situation awareness about who may deteriorate. And you need a timekeeper. Huddles should be standing up. They're not meetings that sit down, and they should last approximately 10 minutes. And they should follow a clear formula depending on what that huddle is about. A huddle in the morning will be very different from a huddle in the late afternoon. So huddles change in their aim. So you've got to have the aim, and then you can work out exactly your structure. And do not do more than once a day until you're satisfied that it's working. Because one of the worst things to happen is to try it, do it half-heartedly, not get it working well, and then the people who are opposed to it will say, I told you so. So this is really applying the improvement methodology. You plan it, you do it, you study it, you make your change. You plan it, you do it, you study, make a change. That's how you do all quality improvement projects, but you have to do it here for sure. Now, the last bit is more difficult. Even before you do your first huddle, role play and practice. Role play and practice. High reliability organizations don't just happen by chance. What they do is they're practicing all the time. So when you look at a football team, they don't just know where people are. They are practicing all the time, over and over and over. That's what we have to do to become highly reliable. We're not really good at doing that. We just do it. We need to, on huddles, practice it before you go on. So when you stage your first one, you're guaranteed it will be a success. And then the next one will be a refinement of the first one until you have your process and say, this is the way we do huddles in this place. Now, to do that, you have to understand the variation. And that means you have to measure. You have to have process measures, which is how you do the huddle, who attends the huddle, how often it happens, what is discussed, etc. That's all process measures. And there are some things you're going to look on the process measures. How you used your SBAR. Do we use it all the time? And the outcome measures depends where you are. It might be transfers to higher levels of care. That could be to increase number of nursing, to high dependency, up to ICU. And that could be the number, or could be the number of days between the different ways of measuring. It could be length of stay, which might be decreasing. It could be cardiac or respiratory arrests, and that usually applies mainly to the children's hospital. For a district general hospital, it would be the number of days between. For the pediatric hospital, it may be something like a rate. Mortality, again, very rare at district general hospitals, but more commonly at children's hospitals because of the nature of the work. But it could be a study of that. And finally, culture. One should measure one's culture either through the MapSap or through a culture thermometer tool and measure it over time, because that's what we've seen has been the biggest difference, the way teams work and the way the culture changes from a reactive to a generative and proactive culture. So this is the SAFE model that we have. Every 6 to 8 hours, or possibly 12, when you have it in full operation, the team will come together for a huddle. They will talk about the safety of work in terms of the framework that I've shown you and will now reiterate now. They'll talk about the reliability of the care delivered, predict the safety of the children on the ward, assess the risks to each patient and those who need to have mitigation or escalation, and have a feedback loop so that they can learn. That's essential, because in order to be highly reliable, you have to constantly learn. And lastly, this shouldn't last more than 10 to 15 minutes. That's a way you prevent it from becoming a ward round or a handover, because it's short, it's brief, it's to the point, and you follow the script. You follow it very carefully, and it becomes reliable. You do the same thing over and over, and you constantly improve it if you need to change anything. So when we studied it, we saw what the barriers and the facilitators were. First, you need a place, the benefits, a place to have awareness. The challenges to that is time, so you have to make time, and the barrier could be senior leadership if that's not available. You then have to have another benefit, which is increased teamwork. The barriers would be if it doesn't fit with existing practice, and the challenges are the potential lack of inclusiveness of junior medical staff. Another benefit is prevention of loss of information. And again, time is often the situation. People say we don't have time, so you've really got to address that. And you really have to look at how you can anticipate and plan. Now, everyone has a view. So these are a number of people who could be here. The clinicians, the allied professionals, ward staff, and ward staff could be the administrative staff, the house cleaning staff, the dinner lady, the play therapists. All of these are important components. The family and the patient, very important to have their view, as well as understanding that they know best, often if things are the same. Be very broad in deciding who should be there, and make it in their own interests. And the only way you can do that is if you include them in all of the discussion. You make sure that you're inclusive at all time. So this is about it. The individual integrates the clinical data into action. Every team member understands their role in responding to the data. They then develop a shared understanding. That is the situation awareness. That's what we call mindfulness. And from that, they have a distribution of their dynamics in order to make changes. And everyone knows their role and how they're going to prevent deterioration, prevent delays, and improve care for patients. So this is the framework that I've taken from the work by Charles Vincent. I spoke about it earlier, and this is going to be integrated in the program. At every huddle, or particularly at one a day, you ask what you did well, so you can replicate. You then ask, did you harm anyone in the last 6 to 8 hours, or 12 hours, or 24 hours, so that you can prevent it happening again? Did anyone fall? Were there any drug errors? Were there any drug harms, medication harms? Were there any adverse events? Any early pressure ulcers? Any undue starvation? Extravasation of fluids, etc., etc., all dependent on your defined harms. Basically, those will soon convert to what you did well. We had no falls, we had no pressure ulcers. So you're converting harms into good, and that's the idea. You then go on to reliability. And the reliability is, are we doing it the way we're supposed to do it? Are we doing what we said? Did we follow the standards, the guidelines, the operating procedures? If not, why not? We then have the human factors part, the SEEPS model, socio-technical, looking at the environment, looking at the way we're working, who we have the right team, the right tasks, the right patients, what's our culture like. Then it gets to the watchers. Are there anyone that we have to watch based on the evidence, the 6 points that we pointed out earlier? Who do we need to watch? And finally, there's the learning point. How did we learn? That happens at every huddle. The huddle's not about deterioration. Now, really, some wards might say, okay, we'll do that in the morning and evening. In between huddles, we don't need to do the full range. We'll just do the anticipation part. You have to adapt to your context. But the key thing is that you have to learn. And each time you are learning, and learning is what it's all about. The more you learn, the better it'll become. So in detail, this is how you can look at it. What did we do well? Identify good practice. Take pride in the work of your staff. Really look at it very carefully. Look at your past harms. You have to define them. Look at the reliability. Are you doing what you're supposed to do? Look at the sensitivity to operations, and there's some key questions there. Really, what's our team like? What does the front line say? Do we have the right staff? Can you anticipate? No, don't think about we can't predict, because you really can if you look at information in a different way. And then finally, what did you learn? These are modified from one of the papers that they wrote after they published this measuring for safety. They were really talking in their papers about higher level, but I think that clinical teams can do it every day as part of their work, so they become proactive and generative. So here are some. What do we do well? Well, this fits in with resilience theory, the fact that most of the time we don't harm. So how do we manage to do it well most of the time? Because maybe we can even improve on that. So that's very important. This is resilience and safety 2 theory happening right in your huddle. So you want to become resilient, and I remind you what it is able to be safe under any conditions, both expected and unexpected. And that's what you're trying to do by predicting and learning from what you do well. Secondly, ask if harm has happened in the past 6 to 12 hours, your common harms. Measure them with a safety cross or a run chart. Report this in real time, not like we do risk management in past time, but in real time. In the last 24 hours, we've had no events. In the last 24 hours, we had events. What are we going to do to mitigate, to prevent it, and develop solutions? Are we reliable? And this goes back to high reliability theory, and I must remind you again, preoccupation with the smallest errors. You want to make sure you get it right all the time, because you can fix the smallest errors, and that way you can prevent big ones. Being very sensitive to operations, which is in the next one. What's going on with the frontline team? Really looking at how you can understand the complexity of what we do and not just simplify it. Being resilient, learning as we go along, and finally listening to the front line who have the solutions. So are we reliable is key to what we do, and are we doing what we're supposed to do is essential to deliver high quality care. And the high reliability really is about improving and measuring in real time, about the teamwork, and about developing a safety culture that is proactive and generative. The huddle aims at doing just that. Reliable and person-centered care, as I might remind you, is the right place, the right time, the right treatment, personalized but standardized in the right clinical ward with no delay, and to happen every time. To do that, you have to constantly study your process, look at the variation, and make a change. What we want to do in the huddle is to ask in real time, were we reliable in the last 6 to 8 hours? And if not, what do we have to do to be reliable in the next 6 to 8 hours? Constantly doing it. We don't do that normally. The huddle gives you an opportunity to do that. Are we safe now? And this is the socio-technical factors, which I spoke to you about earlier in the last presentation. What are the latent failures? What are the problems that we have to deal with in our team? What are the contributory factors, what we often call the human factors, the environment, the team factors? Do we have the right team today? What about the new staff? Do they know the procedures? Do they know their tasks? What about the patients? That's what we have to know about. Do we have patients we don't normally treat? Do we have medications we don't normally give? Do we have different kinds of activities that we have? Those are the human factors that we can address proactively every 6 to 8 hours. And of course, then you're going to look at the features that go on about the active failures. Were there any errors, any harms, any violations, any unreliable care? Because what we want to do is prevent the harm. The proposal here is that you're going to do that as you do in your huddle at least once or twice a day. So the huddle then becomes a very generative and proactive patient safety exercise. Will you be safe in the next period of time, whether it's 6, 8, or 12 hours, to identify children, family concerns, high-risk medications or therapies, early warning signs rising or changing, communication concerns, different clinical teams or parent communication concerns, more than one clinical team involved, the patient in the wrong bed, by I mean they should be in a different ward, this is particularly for children's hospitals, stable, not getting better as they should. All of these are very important, and of course the last one, just not right. The watcher, the feeding, despite normal vital signs. As a doctor, we depend on data. So our data are the vital signs, and we worry about vital signs changing. But when we think vital signs are normal, then we don't worry. Well, generally, before a child deteriorates, they hold on to their vital signs. They don't necessarily go wrong. So we need to be very careful about this feeding. Now, if you take all of these, if the child has any of these factors, they must become a watcher, a child you're going to watch and discuss on the huddle. And these are identified by the clinical teams at the bedside, either the nurse or the doctor. And if they identify any of these, the huddle is the place to discuss and anticipate, mitigate, and if needed, escalate. So this is a tool we developed at Great Ormond Street in order to see if parents could identify patient safety concerns. It's on open access, but we had asked parents over here to talk about anything that they think was harming a child or potentially harming a child, and let us know at the end of the day. And what this led to higher reporting from nurses about potential harms, and it influences the huddle. So this is a tool that's available to you if you want to really find out what the patients need in a more objective way. So this is a huddle suite. Straightforward. Identify at the bedside. Mitigate in the huddle. And that is where you're going to have nurses, doctors, allied professionals, and we're going to really look at the watches, the early warning scores, and the communication concerns. And you're going to escalate. And the escalation goes when you have to call in help, either from the intensive care, a rapid response team, or someone more senior to decide what to do in order to improve the condition of the child. So that's the suite we're going to do. We recommend that you use something like SBAR, which is another way of putting it is ISBAR, which is identify, give the situation, background assessment, recommendation, and a decision. It's a very useful way of making sure you have concise, to-the-point discussions, very brief, and gets to the point very easily. So this is one that we recommend. We recommend an early warning system. This is one from Australia, very successful track and trigger one. There's lots of concern about pediatric early warning scores, about their validity, their sensitivity, their specificity. The key thing is they only give one piece of the puzzle. So you want to use them as part of the system. And in the huddle, they're part of the information, not the only information. So this is one that was adopted at the Evelina and spread in their system. So you can look at different ways of doing it, or you could use one of the many other early warning systems. The key thing is know what they were, how to use them, and understand it is not the score that counts, but rather this being as part of an overall process. The huddle is where you can use it. And here are some of the papers that you can read on early warning systems. One's a review, and one is on between the flags, and seeing how you really got a big improvement by doing that. I'll just add this pass is the iPass, which comes from Boston Children's, which is another way you could use, instead of using SBAR, you could use this kind of information. Now, this is really aimed at handover. And I believe that you need to use a system like this at handover to get reliable transfer of information, so that when you go to the huddle, whoever's giving the next information has got the right information. So even though this is not part of the huddle suite, I recommend that you consider standardizing your handover, because handover of information is one of the biggest threats to children, poor communication. If you read many root cause analyses and reports on adverse events, communication comes up as number one issue that we have to address. So using this as part of your huddle intervention is very important. Finally, you're going to ask what we have learned. Now, unless you're in a learning organization, you cannot really say that you have done the huddle suite very successfully. A learning organization learns. We come from many teaching organizations, but learning organizations are constantly looking at their processes and learning. So we developed a number of tools, and this one comes from the military again, it's called appreciative inquiry. It's asking what happens as an after action review. You say, what happened on our huddle? What was supposed to happen? Why did it happen? What do we need to improve? So for example, did we start on time? Did it go the right length of time? Did everyone speak? That's what happened. What was supposed to happen? It was supposed to last 10 minutes. Everyone was supposed to speak, discuss X amount of children. Why did it happen in a certain way? Someone spoke too much, someone was shy, someone didn't know what the process was. What do we need to improve? That's your constant learning program. Very simple, takes 2 to 3 minutes. But what you have to do is assign someone to lead on it very quickly. So one of your members of the huddle is observing what goes on. When you start, you might want to use this huddle evaluation tool, which we developed on the program. It's open access, there's the reference, and there's the tool. It'll be on the website. Over here, what we want you to do is when you start in your huddles, you use this as your developmental tool. So you use it after every huddle. You want to assess every huddle. When your huddles are reliable and you now got them embedded and they happen as it goes, it becomes a quality control tool. Moves from quality improvement, when you're using it to implement, to quality control, to see that your standards are up, and you do it once a week, once a month, just to see the standards are at the same level that you want them to be. So it's a very useful tool, and it helps you to learn. So that's how you implement the process of the huddles. Now we have another number of measures we think that will be useful for you to use. These are not prescriptive. You have to look at your context, and you have to understand your context to decide your measures. To display your measures, there are 2 ways. One is like a run chart. That's a very good way of doing it. It's a time series analysis. There's your time, and there's your points, your values, and you can see going up and down with a mean and median. There's a whole theory behind it, and you can study run charts, but it's very simple to do. You can use Excel, or you can use pen and paper. And you can just point. So for example, let's say medication errors, or prescribing errors, you can have a run chart just for prescribing errors. How many run charts? Number of prescribing errors per day, per week. Okay, and there's your time, measured once a week. So it could be weekly, daily, monthly. Quite easy to do. Another way, which is quite visual, which is very popular, is the safety cross. Here they call it a safety calendar. Green is no event, so this could be number of children with falls, number of children with line infections, number of children with deterioration. Red is when the event happens. And there you have the number of days between. Very important. So what you want to do is have the number of days between deteriorations, the number of days between being escalated to a high level of care. That's going up. That number's going up. So everyone sees that number, and they see green for each month, and every month there's another one. But that number's going up, so you transfer from one month to another. That's very motivating, and often people can understand this very well. So here are some of the ones you could use. There's the prescribing errors. What we're giving, it's a process measure, and you're looking at the number of errors of prescribing, and then your project will be to decrease that. The druggle, that's a type of huddle aimed at this, would look at that. The measure of the number of percentage of charts that are error-free. That's what your measure is. This is the use of SBAR, the percentage of patients handed over SBAR and formatted any handover. You want to standardize your communication. You want to make sure that you get the right information at the right time, and this is the best way to do it. It's very formalized. We don't like that. You have to have some variation in what you put in your SBAR, but this way improves quality of communication. And then we have the outcome measures. The first one is unsafe transfer to ICU. These are measures that of children who weren't planned to go to ICU and were therefore transferred in an emergency as a reaction. You want to decrease this. And if you're in a district general, that's to increase the number of days between these. If you're in a children's hospital where they're more frequent, you want to decrease the frequency and use a run chart. Length of stay. This could be a balancing measure, really. You might not be part of your project, but using the huddle might decrease the length of stay. Cardiac arrests. You want to decrease the cardiac arrests or increase the number of days between cardiac arrests. Unplanned leave transfer, I've mentioned, to a higher level of care rather than to an ICU. That might be more appropriate for a district general hospital. Mortality. Again, this is rare in district general hospitals, very common in children's hospital. Not as common as in adults, but you want to decrease the number of unplanned deaths. Often deaths are planned because you know the child's going to die, but you want to make sure that you decrease the number. Respiratory arrests, another one more common at district general hospitals than cardiac arrests, but can you prevent these, increase the number of days between the two? So, in summary, the huddle is a way to move from reactive and calculative patient safety to generative and proactive. You're going to implement all the policies or all the theories of patient safety and methodologies, and you're going to ask some basic questions. What did we do well? That's resilience, so we can do more of it. Are there any past harms, so we can prevent and mitigate? Are we reliable? Are we doing what we're supposed to do? Are we following procedures and guidelines and standard operating procedures? Or are we just very variable? That brings in the study of variability. Very important to be safe. Are we sensitive to operations? Are we applying human factors theories? Are we really studying what's happening in the front line? Are we anticipating and being prepared for what's going to happen to our patients by studying them and really looking at the risk factors? And finally, are we learning? Thank you very much.